the second lecture of the block series introduced by Academy of Regional Anesthesia, and today I'll be talking on ultrasound guided interscalene brachial plexus block. So in the next 20 minutes we'll be looking at the anatomy, indications, ergonomics, sonoanatomy and technique of performing this block, and also look at the complications and the clinical pulse of interscalene block. So let's talk a bit about history. Historically, the interscalene brachial plexus block was described by Dr. Alan Viney in 1970, where he used this method to anesthetize the entire upper limb with a single injection using a suitable percutaneous approach. While PNS is used for the identification and isolation of C5 to C7 nerve roots, ultrasound guidance to brachial plexus entered the literature in 1989 when Ting et al. Detailed their success with axillary nerve blocks in 10 patients. And since then, the ultrasound has become a go-to technique for performing the interscalene brachial plexus block. Now, let's look at the anatomy. So we know that the brachial plexus is formed from the lower cervical and the upper thoracic nerve roots and innervate most of the upper extremity, with the exception of the trapezius muscle, which is innervated by spinal accessory nerve, the cape of the shoulder, which is innervated by the the supraclavicular nerves, and a small area near the axilla, which is innervated by the intercostobrachial nerve. Now we know that the anterior and the middle scalene muscles, they lie deep to the sternocleidomastoid muscle and travel obliquely from the anterior and the posterior tubercles of the cervical transverse process to the inner border and the scalene tubercle of the first rib respectively. The fascia surrounding each of these scalene muscles is derived from the prevertebral fascia, which splits to invest each muscle and fuses again at their lateral borders, creating an interscalene space. As the nerve roots, they descend between the two scalene muscles, they travel superior and posterior to the subclavian artery and form the superior trunk, that is C5 and C6, the middle trunk C7 and C8 and T1 forming the inferior trunks. As most of the indications for interscalene brachial plexus block involves the shoulder, so let's briefly look at the anatomy and innervation of the shoulder. The shoulder joint, also known as the glenohumeral joint, is innervated by articular branches of 5 nerves, that is the subscapular nerve, the suprascapular nerve, the lateral pectoral nerve, the musculocutaneous nerve and the axillary nerve, and all of these originate from C5 and C6. The articular branches of the subscapular, the lateral pectoral and the musculocutaneous nerve innervate the anterior joint, whereas the branches of the suprascapular nerve innervate the posterior joint, and the branches of the axillary nerve give innervation to the inferior aspect of the joint. The cutaneous innervation for the majority of the shoulder is provided by the supraclavicular branches of the cervical plexus, which arise from C3 to C4, and the axillary nerve, which covers the lateral posterior portion of the shoulder. Now, we have seen from this anatomy that the interscalene brachial plexus anesthetizes the C5 to C7 nerve roots as well as the supraclavicular branches of the cervical plexus. So it is a reliable block to be given for the major shoulder surgeries such as shoulder arthroscopy, rotator cuff repair, shoulder replacement surgeries. Also acromioplasty, it's a good anesthesia of choice for recurrent shoulder dislocation repairs, and also for frozen shoulder manipulation, which is quite a common procedure to be done in all ORs. It's also used for analgesia as well as surgical anesthesia for various clavicle surgeries. Obviously, you have to combine with some other blocks, and also for proximal and shaft fracture of the humerus surgeries. So what are the contraindications for this block? There are absolute and relative contraindications. Absolute contraindications include patient refusal, presence of open wounds, sores, bleeding or active infections at the site of needle placement, as well as hypersensitivity or history of allergy to local anesthetic agents. The relative contraindications include the uncooperative patients, the patients who have a history of COPD, the patients who have a history of contralateral paresis of the phrenic or recurrent laryngeal nerves, previous neurological deficits of the involved arm, and the overall incidence of bleeding complications following the peripheral nerve blocks in the anticoagulated patient is estimated to be 0.82%. So, current American Society of Regional Anesthesia guidelines recommend utilizing neuraxial guidelines and precautions in the setting of peripheral nerve blocks. So, what about the patient preparation? So, a directed medical history should include conditions that may impact a decision to perform a block, such as coagulopathy or respiratory compromise. It is prudent to examine the patient for pre-existing sensory or motor deficits in the distribution of the block. It also gives us an opportunity to make the patient familiar with the precautions and the care needed during the recovery of the block. The patients who receive the block for surgical anesthesia need to follow the normal fasting guidelines, as the deep anesthesia or general anesthesia may be required for inadequate block. An IV line should be obtained in all the patients. Lipid emulsion 20% and resuscitation equipment should be available in the theatre while performing the block. It's important to do a pre-procedure timeout, which gives us information about about general patients information, patients' allergies, the side and site to be blocked, and also about the various consents. So checklists have been shown to decrease the medical error as well as the incidence of wrong side procedures. Most of the blocks which are administered are done with the patient who is awake to allow communication and minimize the chances of intraneural injections. But if the patient is very anxious, a small dose of 1 or 2 milligram midazolam or 25 mics of fentanyl can be given. During the placement of the peripheral nerve block, the patient should be monitored with ECG, BP, and pulse oximetry as described by ASA guidelines. So once the patient is prepared for the surgery, what is the patient's position? The patient can be positioned in supine, semi-supine, or lateral position with the head rotated away from the side to be blocked. The semi-supine position is preferred as it allows the patient's head to be slightly elevated, allowing for improved visualization and easy identification of the sternocleidomastoid muscle. So what are the scanning techniques? The interscalene brachial plexus block can be scanned in 2 ways. In the first method, as you can see on the left side of the screen, the probe is placed just below or at the level of the cricoid cartilage and medial to the sternocleidomastoid muscle, and the goal is to identify the carotid artery. So as the transducer is moved laterally across the neck, we can identify the anterior scalene muscle, the middle scalene muscle, and the interscalene brachial plexus block sandwiched between the 2 muscles. And this actually appears as a traffic light or a stop light pattern. The second technique which can be used to identify the plexus is the trace back technique. So as the name suggests, the plexus is traced from the supraclavicular area to the upwards to the interscalene brachial plexus. So the probe is moved as you would give a supraclavicular brachial plexus block, and then we move the probe cephalad. Now let's take a closer look of how to perform this trace back technique. So as I said, the scanning starts at the supraclavicular fossa, and the aim is to identify the subclavian artery and the brachial plexus, that is the subclavian perivascular, which is posterior lateral to the artery, and subsequently the probe is moved cephalad to identify the various nerve roots. So this is the posterior tubercle, this is the C6 nerve root, and this is the vertebral artery. As the probe is moved further cephalad, the next nerve root to be identified is the C6 nerve root, which is identified by the presence of both anterior and posterior tubercles, and this is the C6 nerve root. The next is the smaller C5 nerve roots with the anterior and the posterior tubercle. And eventually we can see the C5 coming out of its intervertebral foramen, and the C6 nerve root also coming out, and this is the interscalene groove, which is our area of interest. And you can see this is the anterior scalene muscle, the middle scalene muscle, the internal jugular vein, the carotid artery, the vertebral artery. And this is the place where the block has to be given. So the introduction of the needle can be from in plane from lateral to medial direction, and out of plane from cephalic to cephalic direction, and it depends on the way you are trained and how comfortable or how expert you are in placing the needle. So you can use any of the ways. You can either place the needle in plane or out of plane, but we prefer to do a in plane needling for this block because of obvious reasons, which we will discuss in the later slides. So how do we do this block with ultrasound guidance? Obviously the requirements for this block is an ultrasound machine with a linear transducer which can fire from 4 to 15 megahertz, a block set with a 5 centimeter block needle, as it is quite a superficial block to be given. The local anesthetic agent depending upon the indication for which the block is being given. Availability of intralipid and emergency drugs is prudent before we do the block, and a well-informed and a calm patient is also one of the important requirements for the block. So once everything is settled, the IV line has been placed, the monitors have been placed, the patient is put in a semi-upright position with the head tilted to the opposite side. The linear probe is placed into transverse orientation in the supraclavicular fossa, and using the traceback technique, the interscalene brachial plexus is identified sandwiched between the anterior and the middle scalene muscle. The needle is introduced from the lateral to the medial direction in plane to the probe. And once the needle is so if you can see in this ultrasound, this is the C5, this is the C6 nerve root, this is the anterior tubercle, the anterior scalene muscle, the middle scalene muscle, and the needle is being introduced from the lateral to the medial direction. So the ideal placement position of the needle is between C5 and C6 nerve roots. So once the needle is placed outside the plexus, a test dose is given, and after negative aspiration, the local anesthetic is injected. So as the needle passes the facial covering of the middle scalene muscle, a small give may be felt, and the local anesthetic is given, and you can see in a while the local anesthetic spreading up and down on the side of the plexus. So that's a local anesthetic, and you can see the spread on one side of the plexus. It's not necessary to make multiple attempts or try to encase the local anesthetic on both sides of the plexus. The important point is to notice that the brachial plexus sheath is not a diffusion barrier. In other words, the local anesthetic placed outside the sheath easily diffuses and anesthetizes the nerve roots. Now, effective block will give large area of anesthesia from C3 to T1 and will very occasionally miss C8 to T1 distribution due to lack of local anesthetic spreading inferiorly. Therefore, it is important to check after the block that the patient has had a appropriate anesthesia. So, what about the choice of the local anesthetic agent? Now, the anesthetics or the local anesthetic is determined by the goal of the block and the desired block duration. So, the goal of the block, whether the block is being given for perioperative anesthesia or analgesia, and also by the desired block duration. So around 10 to 25 ml of drug monitoring for effective volume spread and toxic dose limit of the local anesthetic will suffice. So most commonly the drugs which are used are 0.5% bupivacaine or 0.5% ropivacaine. What about the adjuncts? The intent of the adjunct medication is to increase the duration of analgesia without prolonging the motor blockade. Various medications which have been studied are clonidine, dexamethasone, and dexmedetomidine, and they have shown to increase the additional analgesia by around 2 to 8 hours. So, what are the important tips while performing this block? So, nerve root identification and prevention of neuraxial anesthesia is very important. We know that the sonoanatomy and the resulting image of the transverse process allow us to identify specific nerve roots with precision. So, as the nerve roots emerge from the intervertebral foramen, they are encased in a dural sheath for a short length. So, injection of the local anesthetic in the immediate proximity of the transverse process carries a risk of epidural or spinal anesthesia and should be avoided. The second important thing is to put a color Doppler, because to make sure that the needle does not enter any of the blood vessels. Another important tip while doing the interscalene brachial plexus block is to identify the dorsal scapular and the long thoracic nerves which traverse the middle scalene muscle, and is best done by steeper needle trajectory to avoid these nerves, and they are usually found deeper at the interscalene level. So at this particular ultrasound image you can see the dorsal and the long thoracic nerve which can be seen in the middle scalene muscle. Another important point while we doing the interscalene brachial plexus block is the identification of the phrenic nerve and the ensuing and prevention of the ensuing hemidiaphragmatic paresis. So we know that phrenic nerve is a small around 0.5 to 1 millimeter structure that courses around the medial surface of the anterior scalene muscle. If you look at this ultrasound picture, you can see the small black dot which is a phrenic nerve, and also you can see how close it is to the C5 nerve root. So any local anesthetic which is given at this place can easily spread to the phrenic nerve, and which can result in hemidiaphragmatic paresis. So the block, interscalene brachial plexus block using typical volumes of around 10 to 30 ml can result in phrenic nerve blockade and hemidiaphragmatic paresis, and the incidence of this complication is around 100%. So this results in a decreased forced expiratory volume in 1 second and forced vital capacity. So it's best avoided in patients with decreased respiratory reserve, such as the patients who have a history of COPD, interstitial lung disease, pulmonary hypertension, or congestive cardiac failure. So the other complications of interscalene, complications of interscalene brachial plexus block are a block of the recurrent laryngeal nerve causing transient dysphonia, a stellate ganglion block resulting in Horner syndrome, local anesthetic systemic toxicity, and chances of hematoma and infection. So to conclude, the interscalene brachial plexus block is definitely a bread and butter block for shoulder and arm surgery. Traceback technique is preferred to identify and various nerve roots. The risk of neural injury can be minimized by staying outside the sheath, and it is best avoided in patients with low respiratory reserve because of chances of blockade of phrenic nerve. Now we know and we have seen from the presentation that interscalene space in fact is a very tight space, and it is populated with nerve roots, making them vulnerable to injury and carries a 100% risk of phrenic nerve paresis. So we, for the purpose of shoulder surgery, have sort of abandoned the interscalene plexus block and moved on to give a superior trunk block or even selective suprascapular and axillary nerve blocks. and for the purpose of arm, we choose infraclavicular, costoclavicular, or axillary nerve block. Thank you for patient listening.